Hola, buenas noches, bienvenidos nuevamente al Doctor Kardia. Muy emocionados de tener este canal. Vamos a empezar a hacer una de las dinámicas diferentes a lo que hemos estado viendo en un par de videos previos. Como ustedes saben, este año fue el año DAPA. DAPA HF fue el estudio más importante, el más discutido incluso en varias escuelas aquí a nivel del país y tienen muchas opiniones diferentes. Y la realidad es que no solo es que conozcan mi punto de vista en este canal, sino también que conozcamos un punto de vista más global, y como tal vamos a tener la oportunidad y vamos a escuchar de las propias palabras del experto. Vamos a entrevistar, ya entrevistamos al doctor McMurray, el profesor McMurray de Escocia. Nos va a dar su mensaje de cuál es el mensaje principal, cuál es el paciente ideal, y para que también tengamos un punto crítico hacia adelante sobre el mismo especialista que ideó el estudio acerca de qué es lo mejor. Acompáñenos, lo vamos a ver.
Yes, nice. Thank you. So, doctor, thanks a lot for giving me this time. I mean, you know, you are the man of the year in heart failure with your trial that you published. And so, in Mexico, we are so glad about this new information that we have right now of this DAPA heart failure. So, if you let me, I will ask you three specific questions. The first one is, okay, what do you think DAPA heart failure means in the paradigm of treatment in heart failure patients?
Okay, so DAPA heart failure obviously has demonstrated that a completely new sort of treatment that inhibits a sodium glucose co-transporter in the proximal renal tubule, that completely different sort of treatment than anything we've used before, adds significant value to conventional therapy, which is largely treatment that modulates neurohumoral systems, renin-angiotensin system blockers, beta blockers, mineralocorticoid receptor antagonists, neprilysin inhibition. They all act through neurohumoral pathways. Here we have treatment that works in a completely different way, is life-saving, and maybe very importantly is also renoprotective, so you don't see deterioration in renal function, has very little effect on blood pressure, so hypotension is not an issue. And of course, many of our existing therapies, some of the intolerance, some of the problems that we have in using them is because of those types of adverse effects. So we have a new treatment, a very effective treatment, and one that does not really have many of the problems that we associate with conventional therapy.
Right, exactly. I mean, one of the major issues of the other treatments is hypertension, as we can see even with the new drugs. We have a lot of things, and a lot of patients with heart failure have, you know, systolic about 100 or 110, which is limit for other treatments. So what, in your vision, was the perfect patient for DAPA? I mean, for dapagliflozin, I mean, which is the perfect patient in which way? I mean, functional class, left ventricular ejection fraction.
So there's the perfect patient today, and that, of course, would be a patient with heart failure, reduced ejection fraction, who has type 2 diabetes, because currently we can prescribe these drugs for those individuals today. Of course, in the future, we hope the perfect patient will be a patient with heart failure and reduced ejection fraction, whether or not they've got diabetes, irrespective of diabetes. If you're asking about, are there any other characteristics that identify patients more likely to benefit? Well, we didn't really see that. We did lots of the usual subgroup analyses, looking at older people, younger people, people with a lower ejection fraction, people with less reduction in ejection fraction, people with more chronic kidney disease, people with less kidney disease. And no matter what subgroup we looked at, we essentially saw a very similar relative risk reduction Of course, older people, people with chronic kidney disease, people with type 2 diabetes are much higher risk individuals. Their absolute risk is much greater, and therefore, because they're getting the same relative risk reduction, their absolute risk reduction is actually very large. So if you wanted, in a way, to think about what would be the best return on your investment of using these drugs, it would be in higher risk patients because they will get a greater absolute risk reduction.
Which is the patient which are more difficult to maintain in the better conditions, right? So this
You're
is
absolutely right. So it's a very good point you make. So for example, we found that older people seem to get a very large benefit, absolute benefit, and treatment was very well tolerated. But of course, often older people are not receiving conventional therapy, are not receiving a full dose of conventional therapy. So they, in fact, may have responded particularly well to dapagliflozin because they were not getting other effective therapy as much as they should have been, as much as we would like.
yes. I think this point that you're telling me is one of the most important. I mean, this is another treatment, but this is not instead have the other treatment at full dose. I mean, with the full titration of the medication that we know. I mean, with the blockers, ARNIs, for example, aldosterone blockers, etc., right? So this
Correct,
is
correct. You're absolutely right.
exactly. So yes, please.
No, I was just going to say exactly what you've really said, which is that these treatments are all complementary. They work in different ways. Their benefits are additive. So what that basically means is that a patient who gets the 5 available life-saving treatments that we now have, so a RAS blocker, a beta blocker, a mineralocorticoid receptor antagonist, an epilysin inhibitor, and now an SGLT2 inhibitor. So we've got 5 treatments. Patient who gets all of those has got the best possible chance of remaining alive and well and out of hospital because their benefits are additive.
Perfect. And last question: what would what we can expect in 2020? I mean, what is these special things that we can saw in 2020? I mean, what do you think about this year? Is going to be good for our failures?
Right.
Going to be new things?
Yeah, I think so. So already we know that there is another new treatment called vericiguat. Vericiguat is a soluble guanylate cyclase stimulator. We know that a trial called Victoria using that drug is complete. We know from a press release that the trial met its primary endpoint, so it's positive in some way. And we'll see the results of that trial, we believe, at the American College of Cardiology in March. So there may be, again, another new drug, another positive trial reporting in March 2020. And then in the late summer of 2020 in Europe at the European Society of Cardiology Congress, we should get the results of the Emperor Reduced trial. That's a trial with empagliflozin, another SGLT2 inhibitor. So hopefully we will get reinforcement of the findings of the DAPA next year. For may find other trials finish ahead. I think the other trial I'm really looking forward to seeing is a trial called Galactic HF, which is using a drug called omecamtiv mecarbil. That is a specific cardiac myosin activator, ventricular systolic function. It's not an inotrope in a classical way. it improves left ventricular systolic performance. So if that trial also proves to be possible, and we don't know yet, but if it is possible, it will be a very important study, because there is another drug working in a completely different way that actually goes literally to the heart of the problem in heart failure. So 2 definite new trials next year, maybe more surprises as well. Lots of things in the pipeline over the next few years.
Yes, so 3 things. Vericiguat, which is one of that class, something like Riociguat. The Riociguat is only for pulmonary hypertension. Second, another is GLT2, which is empagliflozin, and omecamtiv which is something like inotrope or something like that.
Well, it's not a classical inotrope, but it does improve systolic function.
Exactly. So, doctor, thanks a lot for this time. You're going to see available to see this in YouTube maybe 5 or 7 days from now. This is going to be for my new channel, which is Dr. Kardia. I hope you can follow and see. And thanks a lot again.
Okay.